And without wasting much time, we go on to Dr. Gavin from Singapore, who is going to speak on time for change, integrating faricimab into first-line therapy for DME. So I think we are following the same pattern, that is it going to be first-line for DME or not? Over to you, Gavin.
Thank you very much for the kind introduction. These are the disclaimers. And let's review again the landscape so far. Tim has done a lot of the hard work for me. We know anti-VEGFs have redefined patient care, same as for AMD. It's changed the way we've treated DME. But there are certain limitations, same limitations: frequent injections, patient and caregiver burden, missed visits, suboptimal long-term outcomes. And they don't really address the multifactorial nature of DME. We know DME is a very complicated disease. Faricimab, again, is bispecific, so it doesn't just block VEGF, it also blocks angiopoietin 2. And there's a large program that has evaluated it in various diseases. Let's quickly go into this. Yes, so faricimab is supported by another large real-world data program of more than 150,000 patients that have really proven the good safety profile. So let's go to dive a little bit deeper into the dual inhibition for diabetic macular edema. Tim showed this earlier, where we know increasing angiopoietin 2 drives vascular instability in pathological tissue. And we know in diabetic macular edema in particular, there are many biomarkers that have provided very good evidence for the benefits of the dual inhibition pathway compared to VEGF blockade alone. And when you're looking at the effects of elevated VEGF and elevated ANG2, I think you look on the left, we do know neovascularization and vascular leakage is an important part. And we do know, and I will demonstrate later, there is good evidence reduction of fluid is faster in DME with the dual inhibition blockade. We also see greater resolution of the macular leakage and reduction of hard exudates. We also know it affects inflammation, hyperreflexive foci, a good surrogate on OCT for inflammatory cells in the retina. And I will later demonstrate how, when you look at this biomarker, again, blocking angiopoietin 2 together with VEGF is effective. And lastly, there's some evidence in DME where fibrosis is also protected or prevented with the reduction of development of epiretinal membranes. So again, going back to the clinical trial, you need to understand what they did here in order to apply it to our studies. It was center-involved DME more than subfield thickness 325. And again, the range of best-corrected visual acuity was 25 to 73. The treatment posology was very similar to what we do in the real world. We extended the duration between injections after the loading dose if it was stable. We reduced, obviously, if it was worsening, and they looked at both the anatomical OCT and best-corrected visual acuity. And if there was neither the extension or reduction criteria, you maintained the dosing interval. So in other words, if it was improving, you kept injecting until you got a dry retina. So let's look at what happens to the reduction of macular leakage. Again, in a clinical trial, you have fluorescein angiogram for most patients, almost all. Great advantage over what we do in the clinic. And as you can see here, at week 16, so it's after 4 loading doses in both arms, you're going to make sure it's equal. And there was a very big difference, almost a double, in terms of the median macular leakage difference between aflibercept and faricimab. As you can see, there's a lot less leakage here, 53% less with faricimab compared to aflibercept. And if you want to look back at what happens if you had increased the dose of aflibercept instead, we see data from the PHOTON trial did not seem to suggest a similar difference. Next, we look at the hyperreflective foci. Again, these small hyperreflective dots that you can see on the OCT. And again, they use a size in order to differentiate them from hard exudates. And you can see again, consistently throughout the clinical trial, there are less hyperreflective foci and less hyperreflective foci volume observed in the faricimab arms. And this is both arms compared to the aflibercept arm. If we look at hard exudates, again, hard exudates were segmented from the OCTs, and there was a reflectivity and a size definition. When looking at the hard exudates volume as well as the count in the central 3 millimeters, this is what we usually expect. there's an initial increase as you get drying, and in the long term, it reduces in time. And again, both looking at volume and count, you have that consistent signal where in both faricimab arms, it was less than the aflibercept arm. And that last thing that I mentioned earlier about reducing fibrosis in diabetic macular edema, we know that in a lot of diabetic macular patients, with time, you will get a epiretinal membrane or a vitreomacular interface proliferation. And in the Yosemite and Rhine trial, they did look at the occurrence of this in all three arms. And as you can see there, again, the faricimab arm had less risk of formation of ERM at the end of 100 weeks here. And again, it seems to have a dose-dependent relationship where the 8-weekly dose that had more frequent injections had the lowest percentage. So the take-home message in this first part is that faricimab is a bispecific antibody. It targets both pathways, and the clinical biomarkers show potential in drying anatomical benefits of dual inhibition compared to VEGF inhibition alone. Next, we're going to look at a little bit into the details of the data that demonstrates better disease control. Here, we're really looking at the head-to-head CST reductions over time in all three arms. And so you can see there is a greater reduction both at the standardized time point of 16 weeks as well as overall the course of the entire clinical trial. And if you look at similar data where the approach is trying to increase the dosage or the molar concentration of the drug delivered, we already know the old data from the READ-3 study that did not demonstrate that quadrupling the dose of ranibizumab increased the drying effect compared to 0.5 milligrams. And as mentioned earlier, that's similar in the PHOTON study where a 4 times dose of aflibercept did not appear to provide an anatomical advantage. If you look at how you would want to compare these data, again, we would love for somebody to organize a nicely designed randomized control trial that compares these two newer drugs that we have, 8 milligram and faricimab, but we don't. So as mentioned by Tim earlier, you can use a matching adjusted network meta-analysis where by comparing the features of the clinical trial patients, you can try to approximate what would have happened if you compared these patients head to head. And what they did find was that for best corrected visual acuity, again, you did not see a statistically significant difference, although it trended to favor faricimab. But in the anatomical effect, you did see there was a convincing difference between faricimab and aflibercept, which favored faricimab having a better drying effect. And if you looked at the fluid fluctuations over time, it also demonstrated that there was greater fluid fluctuations in the patients that were treated in the 16-weekly group. You can see over here, that's the dark blue triangles compared with 2 milligrams. So you are getting more and more fluctuations when you go to 16 weeks, even when you quadruple the dose. And that fluctuations is not as pronounced in the Yosemite and Rhine study. If you look at how fast you achieve first drying, defined by the absence of IRF, intraretinal fluid, again, you're seeing that time point is met in the faricimab arms much earlier than in the aflibercept arms. And it was between 7 to 9 injections in the faricimab arms and a much later time point of 13 injections in the aflibercept 2 milligram arm. So retinal drying, we know, is very important for visual outcomes. And obviously, we have seen the linkage between the drying effect and visual outcomes in DME. It doesn't correlate one-to-one, and we know central subfield thickness is not the best biomarker, but increasingly by looking at a combination of total retinal volume, fluid volume, intraretinal fluid volume, and subretinal fluid volume, you have a good correlation with visual outcomes at 12 months in various studies. If you look at the real-world data, this is the Far Retina Iris Registry from America. It does also demonstrate that the improvement in the mean CST in both treatment, naive, and previously treated eyes with DME was impressive or effective. So the take-home message in this portion is you get greater drying in the head-to-head period. And the dual inhibition leads to robust drying effect over 2 years, and that drying effect is demonstrated again in the real-world clinical studies. The last thing I would like to cover in this talk is the durability. And again, can faricimab reduce treatment burden for our DME patients? So we have additional data here where we are looking at the RONEX study, which is an extension study of the Yosemite and Rhine, where patients were then allowed to switch over to faricimab in all arms on a treat and extend dosing regimen. And this went up to 4 years, so you get a greater amount of data. We can see here in all arms, even at 4 years, you maintained a very, very good visual acuity, as well as a very dry retina in both graphs, visual acuity on top and central subfield thickness below. Again, when you look at the absence of DME, at the end of the RONEX study, that was even better than at the end of the Yosemite and Rhine study, where you achieve more than 95% having a dry retina compared with 80% at the end of Yosemite and Rhine. So whatever benefits you're getting from treating continues to extend out in years 3 and years 4. And if you looked at the dosing intervals, at the end of 4 years, all 3 arms which had been switched to faricimab treat and extend were able to achieve more than 75% Q12 weekly or longer, and more than 60% Q16 weekly or longer intervals. We also see again, even in the patients which were switched over from this aflibercept group, you had a drying effect and they continued to improve, eventually achieving an overall percentage of absence of fluid or absence of diabetic macular edema that was quite equal between all 3 arms. And again, we saw earlier that difference 6 to 9 injections with the original faricimab groups, taking up to 15 injections to have 90 percentile dry retina in the aflibercept group, and that improved when you switch them over, achieving that similar 96-97% dry retina after an additional 50 weeks. And lastly, looking at the safety profile, we see that the safety profile as you extend up to 4 years of treatment for faricimab was very, very good and quite similar to all the real-world data that we've seen prior. We also know that the real-world data, and again, this is far retina, far wide, which look at UK and US patients. You can see, again, this is real-world treatment. They didn't follow a clinical trial protocol. As expected, in the first 6 months, you had more injections, a mean of 3.4 in the American data and a mean of 4.4 in the UK data, and this dropped quite dramatically to 1.9 and 1.7 respectively in the second 6 months of treatment. So you could see that you could rapidly extend these patients, and on average, they receive only 2 injections on the second 6 months or less. So to revise and recap all of this, again, we see drying and durability are linked. We see clinical trial data that demonstrates the extended durability of faricimab and continuing to improve at 4 years. And again, the durability outcomes we see in the real-world studies do reflect or replicate the results in clinical trials. I'm going to go through lastly a few cases in my own experience of DME, and I've chosen to show some treatment-naive cases. The first patient was a 59-year-old Indian lady, a preschool teacher, had job demands, didn't really want to come back very often for injection, had diabetic macular edema in her right eye. We started with a loading injection, as you can see, and you get that dramatic improvement, that wow factor, if you want to say, after 1 injection, and it continues to improve. This was one of the earlier patients, so although we saw a dry retina, we didn't want to extend them early. We wanted to see whether completing the loading dose would give us better disease-modifying effect. And with time, we could rapidly extend the patients out. We saw improvement of the diabetic retinopathy as well to mild non-proliferative retinopathy. And in this case, we had an FFA that was also done, and it showed really a dry retina after 4 injections. And if you compare the FFA before and after the 4 injections, you see it's a very, very nice demonstration of what my earlier biomarker presentation covered, reduction of macular leakage. And that was that data. Again, recapping, in the clinical trial, you see the median area of macular leakage at the end of 16 weeks was 53% lower with faricimab compared to aflibercept. The second case that I have may represent some of the cases I know that you get in India, which are very much more challenging, late presentation, poor vision, extremely swollen maculas. In this case, it was bilateral, You see a ton of fluid, it's subretinal fluid, intraretinal fluid, hyperreflective foci, lots of heart exudates. This patient had the works, a young Chinese male. This is the treatment pathology in the right eye, where we again loaded 3 injections. Unfortunately, the patient kind of refused the 4th loading injection here, and then received further injections after that. And you can see there was an improvement. I would say not immediate. Again, this was a very severe case. But even after 2 injections, you had pretty much a dry fovea center, and a lot of the peripheral fluid improved with time. And in this eye, we could eventually extend the patient out to a much longer duration. He had cataract surgery in between as well. And we eventually got him out to 16 weeks, again, with a much improved severity of the diabetic retinopathy, a dry retina, and vision that had been restored to 20/30. We saw similar findings in the other eye. Remember, the right eye was dramatic. He was counting fingers at the start. He ended up 20/30. We did do cataract surgery in between. This other eye was 2100, 580 microns subfield thickness. After just 2 injections, we see significant improvement. He dried out after 4 injections, and obviously there was a little bit of an aggressive extension here where you saw some recurrence. And we went back to the old treatment interval where we got the retina stabilized and then extended again. And eventually being able to go out to at least a 16-week interval or longer in this patient. So to summarize this patient's findings, he ended up with good vision, 20/30 in both eyes. His central retinal thickness improved from 900 to 300 and 600 to 200 respectively. And you can see you had reduction of intraretinal fluid, subretinal fluid, reduction of hyperreflective foci, as well as reduction of the heart exudates in this patient's eyes bilaterally. And again, it's similar in terms of what you found in the clinical trials where you have that biomarker reducing over time. So in conclusion, faricimab provides dual inhibition of both VEGF and angiopoietin 2, and that will address in our diabetic macular edema patients not just the vascular leakage, although it does that better, but inflammation, neovascularization, and fibrosis as well. It offers rapid anatomical control and better drying effect, as you can see both in the clinical trial data, the real-world data, and in my case that I presented. You can get extended treatment intervals that results in less frequent dosing, and there are similar outcomes in efficacy and safety in the real world with the clinical trials. And with that, I thank you, and we can go on to the next speaker.
Thank you. Thank you, Gavin, for very convincingly showing us the drying and durability. 2 Ds we need in diabetes.